Hi, everybody. Terri with DiepCFoundation. We have the DiepCFoundation YouTube channel. We also have the Deep Sea Journey podcast, where you will hear my interview today. And, I'm really kind of excited that you can see behind me the sign PRMA Plastic Surgery. And we are sitting in the practice of PRMA in San Antonio, recording these interviews this week for Breast Reconstruction Awareness Day that they are celebrating on in a couple of days on Thursday evening. But I'm with the president of PRMA, Dr. Minas Chrysopoulo, and we're going to talk about a topic today. We're going to talk about shared decision making and the app that he created for that, because it is a topic that is near and dear to our hearts. And Dr. C and I were having a very kind of candid conversation about this before we got on the recording, because behind our name on LinkedIn, you see that we are both co-leads on the Shared Decision-Making Expert Group. Well, what the heck does that mean? So we're going to kind of talk about that a little bit, Dr. C. But tell us what you do here at PRMA, because I have been sitting in the office for a good part of the day. They have been so kind to give me this space. Door has been open occasionally, but I've been having the surgeons come in and out, do podcasts and interviews. Amazing job that this gentleman has running this practice. So tell us what you do.
I make everyone's day better.
I noticed that.
I try.
I noticed
I don't
that.
know. They probably disagree, but
No, I
that's
noticed
that's the
that. And
goal.
you actually made my day better. And I appreciate you
It's
taking this time
so
out.
good to see you here again.
I know. I enjoy being back. And I was telling Dr. Nastala, I have to tell you, uh, I get a little bit of a warm, fuzzy feeling when I walk in here, sort of, kind of.
Still,
Still, yes, because, I walk through the doors and there's the weight machine. And I remember, that's the first thing you do when you walk in. When I had my consult, hi, Mrs. QT, welcome in. Let's take your weight first. And then they take you back to the consult room. It all just kind of came flooding back to me. Here I am.
it's good that you say that with a smile and not with PTSD, which is very real, of course, as well.
It is very real. And there's other offices I've had PTSD at, but this is not.
Wonderful to hear. Wonderful to hear. Yeah. Congratulations on your inaugural press symposium. That was wonderful. That was wonderful.
I appreciate you saying that, and I thank you for it to this moment. There's times I believe I can't believe I pulled it off. I appreciate you and Dr. Freese being a part of it
It was great.
so much. Your talks were inspiring. They are remembered well by the attendees, and I hope all of you are watching. I am putting those on social media. We have 5 hours of these wonderful talks that they gave that we're breaking apart. So watch out for those over the next few months, because we're getting those out so that people can listen to them who weren't able to attend.
Mm-hmm. And then soon you have to start planning the next one.
Oh, it's October. I'm going back and we have our first planning meeting for the next DiepCFoundation Breast Symposium. Thank you for asking that.
Yeah,
Yes,
yeah.
on my calendar.
There you go.
Yeah, so tell us what you do
What I do.
besides make people's day happy.
Yeah. Well, it's just trying to essentially oversee all aspects of the practice, getting patients through. Ultimately, it's all about patient access and getting them care in the most the most efficient manner, and getting people through at what's typically one of, if not the worst time of their lives. So it's a privilege to be able to care for people, especially when they're facing such a moment of crisis much of the time. So everything that goes into that, I mean, we could talk about that specific question all day, but typically each day is different. We work on processes and systems and just efficiencies, and there's certain things that you deal with a project hat on.
Yeah.
And then you have situations and you have fires and things that just come up that you have to take care of, and that's the day, rinse, repeat. So it's very different to being in the operating room.
Strong sense of business with an overriding note of compassion, I would say.
Yeah. Well,
I'm reaching over here.
if you don't have compassion, compassion is obviously mission critical, and outcomes, right? If you don't have outcomes, then you don't have anything.
Yeah.
So
Mhm.
it's everything that goes into ensuring that we can do our best for everyone.
Mhm.
That's our day. That's it in a nutshell.
You're part of a larger organization now, though.
We are.
And now the reason, okay, I'm pointing to the paper with this work with ARSA. The only reason I want you to talk about that, Dr. C, is because for me, from my perspective, it is providing a broader access to care for patients. And I just came from the plastic surgery meeting in New Orleans and talked to the people there. I'll let you expand on it.
Yeah, so in January of 23, we became part of ARSA, the Advanced Reconstructive Surgical Alliance, and that's a national network. So we're now essentially partners with, to be honest, practices that we used to compete with,
right?
And now we're all partners, which is in some ways really quite surreal. It's absolutely fantastic to be able to share our expertise, to brainstorm our challenges, many of which we have in common, share solutions, and
develop research.
We have several. It's a phenomenal organization. It's physician led, which when you think about large national networks, the term physician led doesn't really come to mind.
No.
But we have an education committee, we have a research and innovation committee, we have a recruitment committee, we have a subspecialties committee, and we have a quality and outcomes committee. And all these committees basically report to the medical leadership, and we get to essentially mold how we develop the network to expand access for patients nationally and now actually internationally, to some incredible, very specialized, mostly microsurgical subspecialties, which has always been really part of the plan here at PRMA, because we've done very well with microsurgical breast reconstruction as our core service line, and we will always remain very, very true to that. But at the end of the day, microsurgery isn't limited to breast reconstruction alone. So we have, even within the realms of breast cancer and oncology in general, there are far more applications of microsurgical expertise beyond breast reconstruction. And so for me, it's almost like a duty. We need to expand our expertise and be able to offer it to other patients, maybe that have been impacted by cancer in a different way, beyond their reconstruction, their breast reconstruction. So joining ARSA has enabled us to do that. We've even hired physicians because of the additional expertise that we now have access to as part of this broader organization.
Talk to Dr. Mercer on a little bit.
Yeah, it's a perfect example.
Yeah.
Tyler's fantastic. Tyler Mercer, Courtney Carpenter joined us at the same time.
Yes. Yes.
Ed Acevedo just joined us in September. He's our first kind of, we have a micro fellowship, microsurgery fellowship for 4 months, a mini fellowship. And then he'll be transitioning to a full associate status in January. But when you look at the interests that they have, for example, Tyler, Dr. Merceron has had a strong interest in advanced nerve surgery. And so when he was considering his options for after his fellowship, he was looking at opportunities that involved, or he was seeking opportunities that involve advanced nerve reconstruction or those types of procedures, in addition to, to supplement his love of micro breast, right?
Yeah.
Of microsurgical breast reconstruction. And so he's now, he joined us. He's done phenomenally well. He's already built a fantastic breast-centric practice. But now he's expanding based on his passions to lower extremity advanced nerve surgery. So a lot of patients, unfortunately, after chemotherapy, they develop neuropathy.
Yeah.
So basically, numbness, and their nerves get scarred.
Yeah.
So there's nerve scarring, fibrosis scarring. That causes, in essence, a type of nerve entrapment.
Yes.
And so when you go in, and there are several areas of the leg that are particularly prone to that as the nerve travels down the leg.
Yeah.
So you can go in and you can actually perform nerve releases in various parts of the leg to help the nerve essentially expand and breathe again. And that helps improve the nerve function. And a lot of people that have chronic long-term issues with neuropathy, and we're talking a year out after the last chemo, these folks get 50% plus improvement after nerve releases. So there you have a perfect example of microsurgery being applied to an area of the body outside of the breast.
Yeah.
Very much related to breast cancer treatment, but not limited to breast reconstruction, for example. Post-mastectomy pain syndrome is another procedure or another aspect. That's a complication of breast surgery. It can happen, despite the name, it can even happen after a lumpectomy because of nerve damage in the breast after surgery. More common with mastectomies. But what happens is the damaged nerve doesn't just lead to numbness, but it also can lead to chronic pain.
Yeah.
And it's potentially very, very debilitating. And so now we're applying our microsurgical expertise to developing that service line. And we reconstruct those nerves, we reconnect them. You can also develop what's called a neuroma when a nerve is damaged. So we excise the neuroma and reimplant the nerve into healthy tissue. So then when it reinnervates the local tissues, instead of causing this pain ball as it's all confused and doesn't know what to do, you're giving it a job. The nerve gets a new job, and then instead of causing pain, it actually does something, and the patient gets better. So those are two really good examples of the benefits of joining a larger organization where you can have your surgeons develop niches that they feel great because they're adding a new service line to the practice to help more people. It's certainly great for their own individual practices because they're essentially developing niche practices, and in some cases destination practices. It's very much continuing the RMA's MO. I mean, that's how you travel to come here for care. So it's a really exciting time. And when you bring all the things that we're doing together now as part of the greater organization, it's a lot of opportunity really to increase patient access to procedures they don't ordinarily have access to everywhere, right? So unfortunately, geography matters.
You nailed it right. Yeah, that's why I'm so interested in it, is because of the variety of procedures that I've learned about through
Mhm.
ARSA. We were both at their summit last year. But it's that access, it's just, I can't tell you how many times I've told patients, but okay, I know someone in the ARSA network that I think might be able to help you.
Mhm.
So it really is casting a wide, very helpful net. So yeah, well, I'm going to say you have really good hair for as many hats as you have to wear. You don't have hat hair, Dr. C.
I don't. Yeah.
So let's make a little segue to the actual words, shared decision making. So is it a science or is it a type of protocol?
I would say it's an approach to delivering care that's evidence-based. So it's a bit of both, right?
Mhm,
So it's the science is there because it's based on evidence-based medicine.
mhm,
Um, but it's more of an approach rather than what I grew up with, which was very much paternalistic.
mhm.
I basically tell you what you should do.
Right.
I'm your doctor. Here's what I think you should do.
Mhm,
Right. Then there's informational, which is it's more complete. Um, more information maybe, and I'm not just talking about risks, complications, that kind of stuff. That's a given. You should always talk about that. But more informational, a fuller explanation, perhaps.
mhm.
But it's still not a two-way street.
Right.
So shared decision making is coming to a decision on the best treatment or what we think is the best treatment through information exchange. So it's a shared decision. The biggest obstacle I think in talking to patients, and there were several at the breast symposium that kind of voiced it.
Mhm.
If you look at the community section of the breast advocate, um, which I also presented about at the symposium, as you
Yes.
know, thank you for that.
Yes.
There's
Very well received.
but there's a recurring theme,
Yeah.
and it's almost as though patients don't feel uh, really even empowered
Mm.
to have that exchange with the physicians or with their healthcare team. So they'll how many times have we seen it where a patient will go in, the exchange happens between with the healthcare team, physician, nurse, PA, whatever, and then they take that information and they leave, and then they try and make sense of it. And then they'll go to breast advocate and post in the community and say, oh, this is what my doctor said, what does this mean, or what do I do? Or so they're seeking to have the conversation, but it's a little late. It's
Yeah.
not late, but it's never too late. But you see what I mean?
Wrong order.
Yeah. So for some reason, there seems to be this for many people, and I get it because sometimes you're lucky if you get more than 5 minutes, right, with your 5-10 minutes with your healthcare team.
Yeah.
So it's you don't have enough time to have a conversation unless you're
Mhm.
prepared.
So I have a question for you.
Yeah.
How many times,
Mm.
I'm kind of tasking myself with this question too. How many times before a patient goes to a consult, I understand you've been diagnosed with breast cancer, any disease that is of concern to you. You get diagnosed, you hear about it, and you set up your appointment. How many times do you think patients take a moment with themselves and say, what is it? What are my preferences before I even get to this consult? what is it that I need to tell my doctor that my preferences are? What is it that's going to be important to tell him in this conversation? I have grandkids. I want to go to their soccer. I want to continue going to their soccer and lacrosse game. I've got a job and I'm certain I can only take 6 weeks. My husband and I really like to how many times, Dr. C?
I think hardly ever.
Mm,
You've just been dealt this blow.
mm-hmm.
You know, this new diagnosis. You think your life's coming to an end. You're worried about it.
Mm-hmm.
You don't even know what there is to make sense of. No one sits there and says, "No, what's important to me?" You know, they don't even know that that's important to ask. So I think this is where the work, you know, you do is so critical, because that really needs to be a very important take-home message for people, and that is, take the time and ask yourself, what's important to me in my life? What is it that I need to get over this crisis to get back to what? What does that look like? So uh, obviously your job is important. Can you get the time off? What kind of support you're going to have? What's your boss like? Are they supportive? Is that going to be another major obstacle to overcome because there isn't understanding there? Or do you have, you know, a really supportive team you can lean on? What's important to you in terms of, you know, do you work out?
I train for a marathon. I don't. I train for a marathon every year. Am I going to be able to run that marathon in a year?
Yeah, you know, I like you said, I like to travel. My family and I had booked this trip, this reunion. You know, this 20-year reunion, and now this happens. And you know, can I make that? Can I get on a boat?
Mm-hmm.
Can I go to the beach? Can I, you know, I do all the shopping, all the groceries. When can I, you know, those bags are heavy. How am I gonna, you know, it's important to have a plan for who's gonna cook, who's gonna do, you know, so I mean, it's overwhelming.
It is. And when we're sitting here talking about things like boats and cruises and soccer games and all that, it seems like why are you going to talk to your surgeon about that? And I'm telling you, because of the process of recovery and what is it that you're going to do to me, Dr. C, that's going to stop me from doing these? Because honestly, all I want to do is get back to my life again.
Yeah,
That's
exactly
why.
it. And it's short term
Mm-hmm.
in terms of surviving the crisis.
Yeah.
And I don't mean from a, you know, mortality perspective. I mean getting through, you know, it's depending on your situation, whether, you know, working or stay at home mom
Mm-hmm.
who's also working, just not getting paid.
Right.
You know,
Different.
you know, if you're a, you know, are you you know, traditional job, domestic goddess, let's call it. What's that look like? Who's picking up the kids? Who's making the meals? So you've got this short term kind of, how do we maintain living and getting through the next few weeks? Because of course here we are focusing on reconstruction
Mm-hmm.
because you're at PRMA, but for the vast majority of people, it's way more complex. It's balancing the rest of their treatment,
Yeah.
right? Chemo, radiation, all these things. So, but when your physician says or asks you, if they ask you what's important to you, it's good if you've given that some thought,
Yes.
because ultimately that is going to play significantly, that's going to play a significant role into, you know, when it comes to deciding what's best for you.
Mm-hmm.
Those are the things that really can sway your decision making, right? Beyond the just, you know, you've got the, you know, do I want the implant look? Do I want a more natural reconstruction? You know, you've got all the aspects of the actual procedures, but the the surgical team knows all that, and that's what they're going to talk to you about. What they don't know is what you bring to the table. So you can't have a shared decision-making conversation unless you're able to express what it is that's important to you.
So in theory, that's what we are doing as a team, co-leads on the shared decision-making team. I provide the resources for think about what you want this to be like. Think about what your preferences are. I provide those resources by interviewing surgeons, doing the podcast. But then, how do we organize all that and get it in a place where we can have it with us all the time and then use that for our consult and to help us continue answering questions? That's where the breast advocate app comes in my mind.
Yeah, no,
I didn't have it. It wasn't developed yet. And I think about, wow, that would be so great if I would have had that. I would have used it so much. Yeah.
Well, when you think about it, about 99% of the thought process that a patient goes through happens outside of the physician interaction.
No
it's not in the
kidding.
clinic, right? It's
because you're in there for hopefully an hour, but not
great
always.
if it's an hour.
30.
We're very privileged here, PRMA, yeah, sure, your consult can be an hour. I mean, we with the app and people being prepared and already being armed with all the medical information,
Yes.
that's kind of reduced the need for really long consults now, because patients come in and they say, okay, yeah, I just,
I'm ready.
I want
This
this.
is it.
Here's what kind of appealed to me, and or
Mhm.
I like implants, or no, I don't want implants at all, or whatever. They know about sensation restoration. They know about all these things, all the different flaps. So then you don't need to spend so much time going over all the options, from soup to nuts, beginning to end, with every single person. That can be 45 minutes, that conversation alone. So instead of that, the way my practice evolved with the app, with Breast Advocate, was people would do the bulk of their research up front on their own. Then they'd come in, they'd have a rough idea already what they appealed to them, what they wanted. I would validate it, see if it made sense for their situation, for their diagnosis, get to know them, get to know what's important to them, make sure that what they were thinking aligned, truly aligned. And I've got to tell you, most of the time they had, the plan ended up being what they came in asking for, because they had the app and they were able to work through it. And then you leave, and then you can revisit the same information over and over because it's in an app. So then the face-to-face time that you do actually have, because you're not depending on that time for information, for medical information exchange as much, then you're able to use that time to really create more of a customized approach for the patient and really get to know what's important to them.
Yeah.
So then, and what we also know with, just like shared decision making as a concept, it's been around since the 80s. It's not new. It's not practiced routinely. It's not standard practice. It should be standard of care, but it's not standard practice, because it does take a little bit more time. But what we do know is that it improves patient outcomes, it improves patient satisfaction, and this isn't just for breast reconstruction. It's been looked at across the whole gamut of medical specialties and subspecialties. But by design, it includes the patient. And when the patient truly understands the reason why you are choosing a treatment approach as a team, if they truly understand the why, then the buy-in is way higher. you're vested as a patient.
Mhm.
And what's really important is if things don't go 100% according to plan, right? Because we all have complications.
Yeah.
The only surgeons who don't have complications are the ones who never operate,
Or
or the ones who are delusional,
yes.
or surgeons who lie.
Yes.
Because unfortunately,
To be honest.
we all, the best surgeons in the world have complications,
Yeah.
right? So they have a lower rate of complications than maybe surgeons who aren't as good, but we
Mhm.
all have complications.
Listen, I just got back from the big meeting.
Yeah.
And they have an entire session on that.
Yeah,
You
you
know,
have to, because
complicated cases.
that's reality.
Yes. Failed cases and what we did. No, it is reality.
Yeah. And so if
Yeah.
if you're in the unfortunate position to experience a complication,
Mhm.
if you know why and you remember the why
Mhm.
you went down that path in the first place, and all the reasons why it was a good idea, and understanding the complications that can occur, if you're in that position, you're far more prepared to deal with it,
Yeah.
right? Because it's
Yeah.
like, okay, well, we knew this could happen, and here's why we did it. I know it was a bigger surgery and this and that, and here we are. We'll get through this together too.
Mhm.
So it really helps with the relationship and getting through badness, because you know e- every surgeon in the world, you know patients think they have the best surgeon in the world. If everything goes smoothly, their surgeon is the best,
Right.
right? That's why we have, every surgeon at PRMA is the best, right? Because, I mean, how can that be? But it is. It
Mhm.
just depends who you ask,
Yeah,
right? It just depends who you ask.
exactly.
Because
Exactly.
every surgeon has so many happy patients. There are
Mhm.
plenty of patients saying that their surgeon is the best. That's the
Mhm.
reality of it. But the rubber meets the road if you have an issue, if things don't go according to plan, and that's where this is also super critical.
Well, I I don't know because I don't ask, I haven't inquired, but I don't know how much of this is being taught in medical school. And interestingly enough, I was on a Zoom conference with the people at Dartmouth who really are some of the, people who started this whole idea. And the discussion was had there. Maybe we need to back this shared decision-making concept down clear into grade school.
I
And
would welcome that.
yes, yes. So it is an important way to communicate. It is how we should be communicating. I appreciate being on a team with you, however that looks, to be able to share this message about this form of communication and decision making with your patient. Always happy to talk to you about it. But we need to it's important for us to tell patients that they have a voice, but it is a process to find out how to use it and how to communicate with your doctor. It is really through shared decision making. That is the concept that they need to know. Yeah, I'm rambling a bit on now, Dr. C, but it's just that important to me that patients find that voice and go through that process, because it really is going to help with their entire process.
Yeah,
So
100%, 100%. And then, the train leaves the station. You're you have a new diagnosis. You're obviously the stress that comes with that.
mm,
Um, but patients also need to know that, especially while they're waiting to see their team, that is the moment to try and think about things, and try and educate yourself as much as possible. Um, and tools like the Breast Advocate app are great, but also do try and think, how you would answer your physician when they ask you what's important to you,
Mhm.
right? Because everyone has a slightly different answer, and it's actually in the moment, some patients have a hard time answering that. It's like, well, what do you mean? What's important to me? I want to live. What do you think is important? It's like, well,
Exactly.
what is it you have to get back to? What do you like? What do you enjoy? What's important in your family? What's all these things? Do try and kind of reflect.
Mhm.
Um,
I think it's an important step myself, because
yeah,
you have time and you don't have to ruminate over it, 2 or 3 days before you go to your consult. Just sit quietly in the morning, sit quietly in the evening, whenever a good time for you to do that is, to just really sit. And, there's an odd phrase, well, what's your life look like in 5 years? Seriously? Think about that. If you have a breast cancer diagnosis, that phrase takes on a whole new meaning. I just think it's so important for women, for people to reflect on that moment. It will make a difference in your recovery, your buy-in with your surgeon, um, all the things.
100%.
What do we always say? We have work to do. I think that in the realm of, talking about the importance of shared decision making, that is probably the most critical thing, I think, in our work together, because it encompasses so much.
Yeah,
Yeah.
agreed.
Thanks for joining me today.
Always.
Good to see you. Good to be back in San Antonio, and good to be back at PRMA. Thanks so much, Dr. C.
Till next time.
Yep. Sounds good.